Hello everyone and welcome to the 32nd International Congress on Pediatrics. In today's webinar agenda, we will be covering rheumatology and pulmonology session. We invite physicians around the world to join us and share their valuable experience with us. This is the fourth day of our online webinar and we're happy we were able to perform it in a timely manner. I hope you haven't missed those 3 days. If so, don't worry because you have access to recorded sessions on our website. I am Dr. Azin Gamari, a medical doctor from Tehran University of Medical Session and the manager of this panel. I would like to introduce today's panelists. We are so happy to have Professor Leila Kheirandish-Gozal with us with the affiliation of tenured Professor of Pediatrics, Children's Miracle Network, endowed Professor of Child Health, Director, Child Health Research Institute, Department of Child Health, University of Missouri, United States of America, on the subject of a sneak peek into the future of the sleep medicine. Professor Vassilios Fanos, NICU and Periculture Department, University of Cagliari, and Italy, on the subject of gut and lung microbiota in acute respiratory failure disease. Professor Sarah Badron, a medical doctor, co-director interventional cardiology, Children's Hospital, Los Angeles, on the subject of heart in Kawasaki disease, what a pediatrician should know. Professor Angelo Ravelli, Professor of Pediatrics and Director of Pediatric Residency Program, University of Genoa, if I pronounce it correct, Division of Rheumatology, Giania, and Italy, on the subject of classification criteria for macrophage activating syndrome complicating systemic juvenile idiopathic arthritis. Professor Sujit Singh, Department of Pediatrics, Head of Allergy and Immunology Unit at Advanced Pediatrics Center in PGI, India, on the subject of Kawasaki disease on Chandigarh, North India, our experience over 26 years. I would like to take a moment to thank our speakers, our dearest panelists, for joining us today. I would also like to take this opportunity to thank Vice Chancellor for Global Strategies and International Affairs, Directorate of International Relations of the Tehran University of Medical Science, for giving me the privilege to patron this important event. I also would like to thank our dearest audience for joining us this event. And I gotta tell that we weren't here if it wasn't for Dr. Ziei and Dr. Aghay Muqaddam. Thank you so much for making this happen for us. Dr. Aghay wants to have a few words with you. Professor, please.
I would like to thank all of our guest audiences for participating in this session. It is our great honor to have you with us. And thank you again. Let's start.
Just a few reminders before we get started. This webinar is broadcasting live on YouTube. A recorded version of this webinar will be available on our website too. Information about our social media is provided in the chat section. Due to the number of participants, please make sure that you have muted your microphone during the lectures. And if you have questions, we encourage you to ask them by the chat section. And there's a webinar tool called Raise Hand that you can use, and we are aware that you have any question, and we will answer your question at the end of the presentation if we have enough time. If you want to receive a certificate of attendance in this Congress, make sure to register on our website and reserve a seat on your desired panel. For Iranian audience, if you want to receive the CME quiz, CME credit, don't forget to participate in the panel quiz in maximum of 2 days in cmequiz.ir. And don't forget to follow us on the social media pages and YouTube channel to stay updated our next events. And with that, we will open today's webinar. We are very lucky to have with us Professor Leila Kheirandish-Gozal. Professor, we are all ears. Thank you.
Dear Dr. Gozal, dear Dr. Kheirandish, hello and greetings from Tehran. Do you prefer to go with your pre-recorded session, or you prefer? Okay, okay. So may I ask for a few words from you, and then we will start it with the pre-recorded session.
Absolutely. Thank you very much, Dr. Aghai. I'm very, very honored, and I'm really thrilled to be part of this panel, elite session of such amazing speakers. I'm very honored to be here. I never thought that I would be able to actually speak to my own colleagues in my own country, far, far, far away, in such a wonderful and amazing way. Although we are all kilometers away, but we are all sitting next to each other and talking. Thank you for this effort. This is amazing. Sadly, that the virus is keeping us separate physically, but obviously the science keeps us all together. So I am hoping that this would be a very good beginning for all of us scientists and physicians, because our aim is to spread the knowledge wherever we are, however we are, together, and help children and adults who need our knowledge and help. I would be very happy and honored to be in this session. I hope that my small contribution would be useful, and I am very honored and ready to answer any questions if there is any, whether after this session or via email later on. And thank you for having me today.
To the speaker for the 32nd International Pediatrics.
3, 2, 1.
Thank you very much for this wonderful invitation. I'm very pleased and honored to be the invited speaker for the 32nd International Pediatric Congress for Tehran University. My topic is to take a look at what is the future for sleep medicine, and I'm very, very happy to be today with you. As you know, sleep apnea is usually associated with multiple physical and social consequences. Many of the physical consequences is also due to the increased obesity that is a known pandemic, as everybody is aware of. Most of the patients that come to the sleep medicine clinic these days are either overweight or obese. Majority of the patients either have hormonal changes, dyslipidemia, insulin resistance or unbalance, higher blood pressure, inflammation, systemic inflammation, and vascular dysfunction, and many of them have excessive sleepiness. By the same token, they have social problems, they have lower competencies, they have poorer attention and memory loss, and overall, they have lesser life quality. Now, I would like to touch base on neurocognitive consequences, which is quite important, and frankly, it is very important to me as a mother of 2 children. We know that children are in a specific age of about younger preschool and middle school are at the window of opportunity for brain growth and development. Now, it is very well known that obstructive sleep apnea in a very younger age is very, very specific due to the enlargement of adenoids and tonsils, and luckily, it is very easily recognizable by loud snoring and is easily treatable. Now, in an older age as well, sleep apnea is quite common. About 40% of adults with snoring have obstructive sleep apnea and is also treatable with CPAP or BiPAP. Now, what is very important is for many, many years, it was thought that obstructive sleep apnea or snoring was just a sound from the upper airway. Everybody thought snoring is just a sound. Nobody ever thought that it had anything to do with the brain. If you look at this study, I put it on purpose here because this was a real cornerstone of many, many studies that later on was published, and it really set the base for everybody to understand that there is a connection between the brain function, the memory, and the sleep apnea. This study was done by David Gozal when he was a younger fellow back in '98. And this study was a very low cost, no budget study. He had the curiosity to look at whether or not children with low school performance, if they had a sleep apnea and they were treated, did they have an improvement in their school performance? So he basically went to the first graders in multiple schools and asked the teachers to overview the worst students in the class. Now, this was a very odd question because usually when you go to a school, you ask the best students to be recognized. And teachers were surprised. So we asked for every class in the first grade to show the worst students and asked the teacher to allow them to have the grade cards. The students that were worst academically, they were chosen, and he asked the parents to allow him to have a sleep study for them at home. Then he, based on the sleep study, he recognized the children that had obstructive sleep apnea, told the parents who needed to be treated, and many of those parents that needed the treatment accepted and went for adenotonsillectomy. And some parents decided that, no, my child snores, I snore, everybody snores in our family, and we don't want to do any surgery or treat it. So they decided not to do, so they opt out from the surgery. He came back in the second year of the same school year and asked the teachers in the second year to give him the grades of the same students, both groups that were treated and the groups that the parents decided not to do the surgery. Both groups had the sleep study in the first time. And as you can see in this slide, I try to point at it. The first grade students that had treatment, suddenly in the second grade, they had a major, significant 6 to 9 times more academic performance improvement. Now, this is not a 1-time or 2-time improvement. This is 9-fold increased performance. This is basically going from failure to almost getting an A or B. This is unbelievable achievement. Basically, this child went from failing the class to suddenly be top of the class. This was almost a revolution in the field because nobody ever thought there was a connection between not breathing, snoring, and being treated and suddenly becoming a better student. Now, moving fast forward many, many, many years later, now we know, after many researchers, many different groups, including our group working on it, we do know that children that have obstructive sleep apnea have many different problems, both behaviorally, emotionally, and cognitively, compared to children that don't have obstructive sleep apnea. Now, we do know that they have prolonged processing. They have visual, auditory, and attention problems. They have social problems. They have thought problems. They have oppositional behavioral problems, such as you tell them to do something, they don't want to do it. Or you tell them not to do something, they do it. They have aggressive behavior. Sometimes they fight somebody at a school. Sometimes they're actually being the subject of somebody else fighting with them. They go to school and they get beaten up by somebody, being bullied. Or sometimes they actually bully somebody. They are having verbal comprehension ability problems. One of the very quite obvious issues that they have is they act as if they have ADHD, but they're really not ADHD patients. And most physicians make the mistake of thinking this child has ADHD and give them medication. And the parents come to me and they say, my child behaves like ADHD, is receiving ADHD medication, but he's not getting better. Now, this is a video that I would like you to pay attention. This is almost less than a 2-year-old baby. As you can see, this very intelligent child is using his executive functioning to plan his escape from his crib. This very happy kid has thought about how he can bring that mattress folded, put his foot exactly the way he should, and then use that to escape out of there. And he's doing it perfectly. And this child, with this very little age, has figured out a way that most children in his age are not doing. Now imagine, this is the use, he's basically making the best out of his ability. That is, most children are not able to do that. Executive functioning is one of the dimensions of our intelligence. There are many other dimensions, but you would be surprised to know that if this child snores and have obstructive sleep apnea, he would have deficit, problem using his executive functioning. This is a problem solving. So this child uses his brain, uses his ability to solve a problem. Now, we know that if your sleep is fragmented, for example, a doctor that is having multiple phone calls in one night that he's sleeping, let's say every 2 hours somebody calls him. The next day, he cannot pay attention. He has attention deficit. That's a patient that has sleep fragmentation. On the other hand, somebody who doesn't have a sleep fragmentation but has a very, very severe apnea, hypopnea, or has a lot of low oxygen, next day he has bad behavior. He doesn't have an attention problem. Instead, he actually acts in a mental processing way. He basically doesn't remember things. Now, these are based on the research that are for many years had been worked through our group and other researchers. Now, to show you one example of the studies we have done, this is a study that I designed about almost 10 years ago. This was a simple study, but very clearly shows if you get a group of children that are coming to have a sleep study, we don't know if they have obstructive sleep apnea or not. We just have them look at a bunch of pictures of animals that are simple for a child of younger age to remember. Let's say cat, dog, horse, very simplistic pictures of animals. They are all identical. And then we close the book and say, hey, do you remember what animals we saw? And then the child needs to remember what he has seen. So the first time out of, let's say, 25 pictures, the child may remember 10 of them. When you open the book again in the next trial, the child remembers this time maybe 15 of them. With the third trial, the child learns 17 of them. So by the last trial, the child learns almost 20 or 21 or 2 of them. Now, these multiple trials, which is learning curve, allows any child to learn to the maximum they can. Now, we repeated this until each child reached his best. Now, that was what we call a short-term memory. And then we allowed basically a maximum score for each child, basically to reach their best they can. And then we allowed them to sleep, and we didn't tell them we're going to come back the next day. So they won't practice with their parents, or they won't practice or repeat with themselves. So they thought the test was finished. But they woke up in the morning, I showed up and said, hey, remember we saw a bunch of pictures and animals? Can you repeat that? So on the right side, you can see in a square, black squares, are the children that actually had obstructive sleep apnea. The children that had obstructive sleep apnea learned exactly the same numbers and exact same animal names, but it took them longer and many more repeats to learn the same animal names and numbers compared to the children of the same age, same sex, and same conditions. But when they finally learned the same thing and they slept, because their sleep was interrupted and it was obstructive sleep apnea that disturbed their sleep, the next day when they woke up, they couldn't remember even the things that they learned perfectly the night before. To make it simple, this is a child that you sit with him, he had, let's say, geography test the next day. It's your kid, it's at a school, 3rd grade, 4th grade. You memorize a bunch of capital of cities or world or whatnot, and then he goes to test and comes back, and you know that they learned it, they repeat it at home, you know that they knew it, but they didn't get the full grade. And you say, why? I knew you knew it. Why didn't you get a best grade? Well, what happened? And he said, Mommy, I couldn't remember it, or Daddy, I couldn't remember it. And you don't believe it. You say, why? And the child doesn't know. And they're telling the truth. They couldn't remember it because your child has a sleep apnea and it's not treated because their brain is not functioning the way it should be. Another topic that is super important and I really would like to talk about is empathy. Empathy is how we feel about somebody else's pain. Is our sense of feeling somebody else's miserable feeling or pain or being sensitive to somebody else. Now, it has been shown that children that have obstructive sleep apnea, they are less sensitive to somebody else's pain or sadness. At the beginning, everybody thought that maybe it's just some sort of a psychological behavior. But the truth is, there's a part of their brain in their amygdala that is actually affected. Now, here is a very simplistic picture, but I think this will help. In the middle, you can see a scene. A child's hand is stuck in a car door. Any normal human on the right side, such as hopefully you and me, when we see that picture, we feel that, ow, that's a painful thing. When you feel that, ow, the right amygdala in your brain should be activated. That's where we feel the pain, the empathy, the feeling sorry for that person that we don't know him, but his hand is stuck in that car and it should feel painful. Now, if we are psychopaths, like Hannibal Lecter on the left, not only we don't feel anything, it's as if we saw a bird flying. You don't feel nothing. That's why psychopaths kill people, skin them, eat them. They don't feel nothing. As if they're watching a movie about, I don't know, a leaf falling from a tree. They feel nothing because their amygdala is not activated. Unfortunately, studies, especially in our laboratory, we have shown that in a sleep apnea, children with obstructive sleep apnea have less activity in their amygdala, which probably explains why when they go to school, they get into fights. Maybe because they feel less pain, not physical pain, less empathetic activity is there. So they kick somebody because they don't feel as sensitive to the feeling the other person. Now, this is very important, and I would like you to really pay attention. Just look at the left side. Every yellow color that you see is the actual erosion of the surface of the brain. These are actual images from the functional MRI. These are brains of children that have obstructive sleep apnea. Every yellow part is the part that actually been eroded from the gray matter that from these children had been eroded because physically there's a brain volume reduction if obstructive sleep apnea is not treated. This is really, really important. Most people thought it's just a behavioral thing. It's just maybe an activation or disactivation of something. But this actually tells you that not only you behave differently, you also physically lose parts of your brain. You physically lose parts of your neurons. And we all as physicians know that neurons in the brain are something that doesn't easily replace. Now that probably is why if you are having obstructive sleep apnea and you're not treated, you can lose up to 10 to 12 points of IQ. Now, if you are an intelligent, superior person, like yourself, any one of you in this lecture listening, or your children, if your IQ is about 120, 130, I'm sure if you lose 10 points of IQ, nobody would notice it because you're intelligent already. Nobody notices the change. But imagine you are a person with the IQ is starting already with IQ of 95, and then you lose 10 points of IQ. Now your IQ is to a limit, to a very lower limit. That means this person is not going to be able to go to university, is not going to be able to get a job. He's going to be a burden, he or she is going to be a burden to himself, to his family, and would never have a normal life. This is a major burden on health, on society, on himself, and on his family. This is not something that we couldn't detect, and this is not something that we couldn't treat. If it's something we could have treated, we should have treated it. Now, you may say, how do you want to detect that? Well, very simple. Look at this study about 2007. We showed children that have obstructive sleep apnea and neurocognitive deficit, very simply, their CRP is high. So when you have a sleep study, you have a child, look, the CRP, just a simple CRP from the blood, elevation of that can be a marker of children with neurocognitive deficit. So please, when you are doing a sleep study, have a blood next day to make sure at least it would direct you towards, as a biomarker, it can direct you toward a child that is more susceptible towards the neurocognitive deficit. Now, this is another topic that I would like to talk about, because you may say, okay, something in my throat happens. Because of that, something in my brain gets damaged. What is the connection between the two? How is that happening? Well, the connection is your blood vessel. Okay, now it's complicated. How my blood vessel is connected to my brain. Brain doesn't have blood vessel. So what's going on? So the endothelium, which is a single layer of cells lining inside your blood vessel, is the key. Imagine this is a child that comes to a sleep center, sleeps there. We measure the function of their blood vessel. We take a blood next day in the morning. Of course, usually they're not happy and smiling like that, but let's pretend. And we do a neurocognitive test, and then we run and give the blood to the scientists in the lab. Now, you would expect that every child with obstructive sleep apnea would have a very bad blood vessel function, because blood vessels should be affected. That is usually like that. Problem is, in the severe obstructive sleep apnea with obesity, there's a group of children that actually have neurocognitive dysfunction, and there's a group that are not. And there's a group that have severe OSA with obesity, and their blood vessel is completely normal. Now, how is that even possible? This basically means there is about 30-something% of children that are fat. They snore like crazy. They're choking every night, but there's nothing wrong with their blood vessel. How is that even possible? That's a whole puzzle. That brings us to another concept. Again, what goes to the brain and what doesn't go to the brain, and who takes what to the brain. That brought us, after many, many years of thinking and searching, to something that is called blood-brain barrier. Now, you remember from your probably biology and physiology that brain is the only organ in your body that has its own security system. The security system in the brain is actually a network of blood vessels that allows for the entry of certain nutrients and essentials to the brain cells and blocks the other stuff. So it's completely different than other things. So it's one layer of cells that allows for things to pass and some things not to pass. It's very selective, and it's called blood-brain barrier. That barrier is very, very tight. It's like a tight junction. It doesn't allow for anything that it doesn't want to pass. It's almost like that big wall in the Game of Thrones that Jon Snow said nothing will ever cross the wall. As all of us know, he knew nothing. Now, jokes aside, this is what's happening. Obstructive sleep apnea causes inflammation and oxidative stress. Something, which we're going to talk about, takes the insult through the wall being the blood-brain barrier, disrupts or breaks or somehow goes through the tight junction of the blood-brain barrier of the brain and causes our brain to malfunction or make our cognition lesser or dysfunction. And that's something, my friends, was discovered about 10 years ago, being something called exosome. Now, exosomes were discovered about 10 years ago. They are nanoparticles, they're extremely small, and they are almost like mailman or postman, that a cell wants to send another cell a message. They put the message or text in a little envelope or something, and they say, hey, exosome, take this to my friend, from secreting cell to another cell, and this is extracellular messaging. So exosome is basically maybe little car, or it's like what we call in Iran, peik, peik motori. It takes your message from one cell to another. So exosomes are those. They just take it from here and take it there, back and forth. So the exosome takes that message from here, from the vessel that is hurt, all the way to blood-brain barrier, passes through that, goes to your brain and say, hey, the obstructive sleep apnea says, start acting stupid. Now, how do I know? Because this is very simplistic, but I want to put it this way to make it easy. Let's say we do a sleep study, we do endothelial test to make sure that the blood vessel is affected. We got the blood, we got the exosomes out of the blood. We put the exosomes there and we check, make sure we mark that exosome so later on we can follow it. These are little technical issues that this by itself from here to here is almost like a year of work, but let's just forward. And then we put these exosomes, the messengers, injected into a poor mice that has no idea what's going on, and then measure their endothelial function. What I expect is that if the blood came from a person that has obstructive sleep apnea and endothelial dysfunction, that means that message says your brain should act really, really bad. Your brain should act like somebody who doesn't have much of an intelligence. Go act as stupid. Now you may ask, how do you get a mouse to act non-intelligent? Well, this is how we do that. We put a mouse into something called novel object recognition test. It's an empty box with two objects. One object is basically a solid object that mouse has seen before. One object is a new object. If a mouse is intelligent, he only goes and explores the object that he has never seen before. He leaves the object that he has seen before. If a mouse is a dumb mouse, in a way, or non-intelligent, to say it correctly, he will keep going to the thing that he has seen before because he doesn't remember it. It's like a child that has a toy, and once he plays with the toy once or twice, he doesn't want to play with it anymore. But if he doesn't remember it, every time he sees it, he's like, oh, an exciting red object, an exciting red new toy. Let me go check it out, a sniff, a sniff, a sniff. And then he goes back again and back again and back again because he doesn't remember it, he doesn't remember it, he doesn't remember it. So the computer on the right, the right side is actually the same measure, but computer measures the distance, the time that the mouse goes back and forth, back and forth, back and forth, and every time checks it out. A mouse that is intelligent will just go once and says, oh man, I've seen this before, no thank you. That's how you know if the mouse is actually intelligent, has a neurocognitive function correctly or not. This is one of many different ways of measuring the cognitive function in rodents, for example. Another topic I wanted to bring to you is actually a very hot topic of sleep and cancer, which is quite recent and very hot topic these days. We know that sleep is quite related. If you sleep fewer hours, you're more likely to have a more aggressive breast cancer. If you have an irregular circadian rhythm, for example, people who have night shifts or people who are flight attendants, they keep going back and forth, they have more likely chance of having breast cancers. If somebody sleeps a lot, longer sleepers, especially men, they're more likely to have colorectal cancers. And it's been shown that a sleep disruption, somebody who keeps getting asleep, repeated breaking of the sleep, somebody who gets calls and calls at night, may have an increased risk of prostate cancer. Now, what we have done in our group, almost 3 years of continuous experiments and many recent publications that we have, I'm just showing one of them, a large number of experiments, we have shown that when you expose an animal to the intermittent hypoxia, which is our way of creating a resemblance of obstructive sleep apnea in an animal, you make the cancer cell much more larger and much more aggressive. Not only the cancer cell becomes much more bigger, it also grows much more faster and goes deeper. We know that intermittent hypoxia and cancer are so related. As you can see, from 2012 until now, almost 8 years now, multiple groups have looked at multiple different types of cancers, and there are connections. Some of them are worked by our group and some of them from different laboratories. It is important that if you are a patient or you know a patient that has a sleep apnea or irregular sleep, at least help them, if they have a cancer, to sleep better. Sleeping better helps their cancer treatment and improvement in their overall treatment. Now, the final thing that I would like to talk about is fresh off the oven. 2 weeks ago, we had a publication that made the news. This is about what you eat can affect your sleep. And this is about sleep and gut microbiome. Now, it's been known for almost a few years now that gut microbiome can change many different things, but nobody ever thought about gut microbiome having effect on your sleep. Now, this is a very simplistic slide just to show you the concept. Bunch of mouse were put into either obstructive sleep apnea model, which is intermittent hypoxia, or breathing normal air. We collected their fecal samples and feed the fecal samples back into the normal mouse. They're all identical mouse. Now, we didn't feed them, we actually injected them back. These received the sick, basically, fecal samples, microbiome from the sick mouse, and these received the microbiome from the healthy mouse. So their sleep was not changed, and the group that received the microbiome from the group that had obstructive sleep apnea actually started to be very sleepy and sleep more. Very, very revolutionary, meaning there are certain things in your body that changes. In your guts, if you can change what is in your microbiota of your guts, you may be able to improve your sleep apnea or your sleepiness. This is incredible finding. This is very revolutionary. And we are, as we speak, talking about new projects. We are thinking about use of certain ways that may open new doors for treatment without surgery, without having to give medication in a very different way, instead of using the upper airway, actually going through the guts. This work was done by our very, very new fellow, Mohammed Badran, who is a very young fellow, just recently joined us, less than a year, Dr. Khalifa, and in our laboratory. And this was extremely well received. Over 4 million view has been over in the last week, and I really wanted to show it to you. Well, this wraps up my lecture for you, and I'm very honored and pleased that I was invited. Thank you for your attention. And I would like to acknowledge all the people that helped me will help us in our laboratory, and also the two people that actually passed away, the Professor Maylus Alonso Alvarez and Professor Joaquin Teran Santos. Both of them passed away in the last year, and this has been a major disaster, but they helped us with the project with cancer. And thank you for your attention.
Thank you very much, Dr. Kheirandish, and I should apologize for the inconveniences with the internet connection. It was not secure, so we have some problems with that. So sorry about that.
It's okay, I understand.
And I should I should thank you for answering questions rapidly in the chat section. Thank you very much. So if I may, I would like to ask Professor Fanos. Welcome, sir. Thank you very much for participating in this session. I would like to ask him to continue with his very valuable presentation. You can ask your questions in the chat section from dear Dr. Kheirandish. She will be with us during the remainder of the session.
Just a minute before Professor Fanos gets started, I wanted to ask one question from Professor Kheirandish. In fact, it is out of your presentation, but who is in your center in charge of sleep apnea, a cardiologist or a pulmonologist?
Pulmonary hypertension.
Yeah, depends. Each center we have different, in each university there had been different groups. So the way it works in USA, I apologize, Professor Fanos, if you don't mind, I'm sorry. I will just be very, very quick. In each center is different. At this university, the pulmonary group is the one in pediatric, and in the adult center, it's the neurology. But there is only one umbrella for the fellowship that is always taking over. So pediatric and adult has to be joined. So we cannot have separate ones. So although we are pediatric specialized, but when you go through the fellowship, it's only one program. So we are trained in both adult and pediatric, but later on you can decide which one to practice.
Thank you for your answer. Now it's time to Professor Fanos. Professor Fanos, we have followed your speech yesterday, and it was more than fascinating. All of us were amazed here, and we are interested in it, and we are willing to listen to your lecture. Thank you.
Thank you very much. Can you hear me? Can you see my screen?
Yes, yes, Professor, go on. Thank you.
Thank you for your comment, dear friends. Again, thank you very much for inviting me and for giving me the possibility to give a second lecture. So my job today will be to talk to you about gut and lung microbiota in acute respiratory diseases. And I thank also the previous speaker. I thank very much because she paved the ways, as we say, with the last slides to my presentation. And this is the agenda of my presentation. And the subtitle of my talk could be "The Dark Matter," or if you prefer, the unknown unknown. And 4 topics, but the backbone of my talk will be acute respiratory disease and coronavirus and gut-lung axis and microbiota. And the story starts from this paper that I published in the journal of which I'm editor-in-chief, which is also the official journal of the Union of Middle Eastern and Mediterranean Pediatric Society and other international societies. And in a few months, we had 12 citations. And another inspiration could be this paper, which is one of the last I published on PubMed, the dark matter of microbiome, the mother-infant pair virome. Because when we talk about the microbiome, we normally think to bacteria, but there are also the virus, the bacteriophagi, the fungi, and helminths, and protozoa, and so it's a dark matter, really dark matter. And what about coronavirus in newborn children? We are drawing in COVID-19 papers. In fact, as you can see in PubMed, about 25 papers are published per hour. So it's very difficult for everybody to follow all this literature. And this is our invisible and terrible enemy. And this is the attack to the lung cells of the virus particle. We studied in a deep way this attack, and what is important to tell you by me is that the localization of ACE2 receptors is diffused in all the organs, not only in the lung. Today it's possible to, with immunochemistry methods, to capture the real localization of, for example, in the intestine. But I want to share with you these slides because very few people knows that in the intestine the number of ACE2 receptor is 4-fold the number that is present in the lung. So this is interesting. In children, we have less receptors in the tissue, as less affinity for the virus. This is one of the reasons because the children are less affected. And let's see in the last part of my talk. And again, we studied the relationship between pregnancy and coronavirus, what we know, but also what we don't know. For example, vertical transmission is still controversial. And another important topic to me is the offspring's long-term outcomes, because nobody knows what happens even in asymptomatic children later in life with the so-called and well-known process of the fetal programming or perinatal programming or developmental origins of health and disease. So we know the distribution, the different ages, and the numbers, as we say, and we know, matter. And the age distribution in hospitalized children, this is a paper from the United States, is higher in the first years of life. And also the number in intensive care unit admissions is higher in the first year of life. Most of these children present important concomitant diseases. And this is the panel of the symptoms in children with COVID-19 disease. But you know that this topic is interesting because the syndrome of coronavirus could be present with diarrhea without fever and cough. And this is a problem for the containment of the disease. And if we look at the multisystem inflammatory syndrome in children, we can see that diarrhea and vomit are present in a very high percentage of cases. So the presence of diarrhea and vomit of gastrointestinal symptoms is very important for the physicians. This is a paper that is not just published, it's on preprint, it's a preprint, but in a very high number of children during the lockdown period in Italy, we are initiating another, unfortunately, lockdown. And we were able to demonstrate that the presence of diarrhea and fatigue, unexpected and unexplainable fatigue, in absence of sore throat and ERH and abnormal skin size, is a very strong predictive symptom for a diagnosis of COVID-19 disease. Even without the execution of the analysis of molecular analysis. And in particular, you can see that fatigue and nausea, vomiting, and diarrhea are very important in absence of sore throat, ear ache. So we studied also other organs, for example, the heart or the kidney, which is not a figurant, it's a protagonist to me. But let's move to the microbiota. This we know from very interesting paper that it is very important, the maternal microbiota and the infant microbiota, and these are related also to the most important epigenetic factor, which is the nutrition. And in moving from the first trimester to the third trimester of pregnancy, there is an alteration of microbiota, which is similar to that of diabetic and obese mother. There are microbes that are great extractors of energy. This is functional to the acquisition for the newborn at birth and for the placenta of healthy bacteria for the newborn. We know from elegant studies with germ-free animals. And also we know from this paper and other, the strict relationship between the virome and the microbiome, because if we take the pregnant women at the third trimester of pregnancy and obese non-pregnant women, they have a particular vulnerability to influenza virus. And if we perform vaccination in these women, they are able to produce a very few number of antibodies and less efficient antibodies. But the strange thing, if we perform a transplant of the microbiota in animals, of their microbiota, we are able to transmit these two properties. So what is the key message for you is that the microbiome and the virome and the third brain, which is the immune system. The first brain is the first brain, the second brain is the gut, the third brain is the immune system, connected together to determine something that we don't know, that like the previous speaker very efficaciously talked. And we have different epigenetic factors that could be a relevant factor for this dysbiosis. I wrote a whole paper on the pioneers back that are responsible for a good health or a bad health. And lactobacilli are the pioneers backs. And please note also the birth weight that is related to the placental microbiome, to the placental lactobacilli. And please see in the first days of life how the increase of bifidobacteria and lactobacilli is important in the colonization of the human newborn gut. Lactobacilli are the bags that kiss the mucosa because they are able to stay just in front of the mucosa. All the other bacteria stay in the mucus. And the bifidobacteria represent 1/2 of the neonatal microbiome, and both are all friends of our species from 200,000 years. They are represented defense for our organism. And we as mankind had evolution with the co-evolution. Each evolution is a co-evolution, and we had a co-evolution with this bacteria. And one of the problems today is the presence of bifidobacterial dysbiosis, preterm prematurity, cesarean section, newborn infants fed with formula, antibiotic treatment. And I showed this slide also yesterday, and we are studying the dysbiosis in necrotizing enterocolitis, and please see the microbiome. See only the colors because it's impossible to make a comment on these slides in a quick way. And it is very different from controls and necrotizing enterocolitis. And we have very different species of bacteria colonizing the gut. Something which happens in this very vulnerable period of life could be related to important disease later in life. Just remind to obesity and also to autoinspector disorders. And now let's move to the backbone of my presentation. And I would like to suggest this fantastic review with fantastic panels to understand the gut microbiota. I have no time to describe the physiology and the physiopathology of the gut microbiota. You can find excellent papers in the literature, and I also remind my book that has been translated in English and then in other languages, in Greek, in Romanian now. And we know what happens at the level of the cells, and we know that also the lung has a microbiota with normally 6 bacteria. And the difference is that in the gut we have one human cell each 10 bacteria, but in the lung we have one bacterium each 100 cells. So the difference in the quantity of cells is 1,000. And we know that in respiratory disease, there is the gut-lung axis. We know very well that now the name of the bacteria that are present during normal head or bad head. And we know that in all the viral infections, children and also adults present diarrhea, vomiting, abdominal pain, and also in animals it's the same. So there is an involvement on the intestine during viral disease, you know, like me, this detail. And this is true for some important disease like influenza A virus infections, which is related to dysbiosis, and the consequence of the infections is also dysbiosis. So there are some vicious circles on this argument. Again, we have other papers, and the impact of the dysbiosis is related to the caloric restriction in experimental animals. But the most important thing to me to share with you, and I think it's a cutting edge, this topic, is the relationship between the gut microbiota and COVID-19 disease. And now we know from very recent papers that there are alterations in the gut microbiota of patients with coronavirus infection at the moment of the hospitalization. In particular, you can see that there are a reduction of some good bacteria like Faecalibacterium prausnitzii and Roseburia, and there is an increase of bad boys bacteria, as I call them, like Clostridia, on other bad boys like Vassilios. And this is very important because you know that Clostridia are related in the organism to preeclampsia in the pregnant woman, to necrotizing enterocolitis in the newborn, to Crohn's disease, rectocolitis ulcerosa disease, autism spectrum disorder, and even stroke in the cardiac stroke in the adult patients. So this slide is very important to me because what happens normally, there is a bidirectional relationship between the gut and the lung, and normally the gut produces, you know, the short chain fatty acid, and the butyric acid is very important, and reaches the lung and contributes to the equilibrium of the lung, not only by the biochemical cytokine point of view, but also of the microbiota. In each respiratory distress syndrome, in each viral infection, there is the phenomenon which is called more of the gut in the lung. So the bacteria of the gut moves towards the lung and colonize it, and you know there are a lot of bacteria that normally are not present, because normally there are bacteria derived from the oral cavity. And not only it's a problem of quantity, but it's a problem also of quality. So I wrote this instant review, and then this observation was confirmed by other researchers. This is a very elegant panel. I have no time to discuss that, but I would like to share with you with a more detail these slides. This is an adult patients who in intensive care unit who are intubated have Enterobacteriaceae in their microbiota of the lung. Those who are not intubated don't have Enterobacteriaceae. That's incredible. It's a dramatic difference. And those who are intubated present and will die, present a very high concentration of Lactospiraceae. So the importance of the microbiota is extremely high. And today there are very elegant studies with the omics technology like metabolomics and microbiomics, and I told you yesterday, and it is possible to clearly discriminate healthy microbiome, a microbiome of community-acquired pneumonia, microbiome of COVID-19 disease. And I was very surprised when I read this paper related to the outcome of children with severe coronavirus disease infection and admitted in the neonatal intensive care unit of Canada and United States, because only 17% were treated with antibiotics and were treated with macrolides. But what happens is that these children have like the adults, have the phenomenon of more gut into the lung. So it is not possible to leave these children without antibiotic, and only 17% were treated with azithromycin, which is not efficacious against Enterobacteriaceae and all the bad boys coming from the intestine. We know from some studies that also for an unknown reason, the antibiotic-treated children has a decreased viral replication. Don't ask me why, because nobody knows on the surface of the earth. So we published some papers about that, microbiota, and which came first, the chicken or the egg in coronavirus. And maybe that the protection due to the magic of human milk could be related not only to lactoferrin, not only to stem cells, but also to the microbiome, which is related, as I showed before, lactobacilli and bifidobacteria. Now you can understand why I talk about the newborn, and now I'm talking about the child, the adolescent, and the adult. And I want to show you this slide is one of the 6 metabolomic studies that have been performed. It is possible without any overlapping to understand the healthy patient and patient with COVID disease and the different grading of the severity of the disease related to high level of interleukin-6. Because when you have the phenomenon of more gut into the lung, the interleukin-17 is substituted by interleukin-6. And so what happens is the cytokine storm, as you know. And it is possible to go into depth of the information and to understand all the pathways, all the metabolites that are involved in this issue. And you can see very elegant studies. So you can capture the complexity of what happens in our organism with creatinine and transaminase. You need to have a tremendous complicated technology like the omics. These are other papers so complicated that are difficult to read, and many physicians don't read because they are too complicated. It's possible also to pharma metabolomics to anticipate the effect of the drugs. This way with an urine sample or a blood sample. So I think that's a very important topic, and as I suggested to you yesterday, metabolomics, microbiomics, and machine learning, the 3M, could be the future in research in medicine. And I can anticipate to you that we could have a picture like this, a patient, they are the same clinical picture with mild symptoms and signs, but this patient will go to intensive care unit and will die. This patient will be discharged, but he will or she will have a pulmonary fibrosis, and this will be really mild, symptomatic, without any problem later in life. Why I am showing you this slide? Because we can capture the extraordinarily strong inter-individual variability that I discussed with you yesterday, and very important study. This is another study on microbiomes. Look at this detail. It is possible to correlate in a fantastic way all the metabolites that are related to the microbes, and also to interconnect microbes and metabolites and heavy and deep of information that could be useful, because what we can do today is we can change our microbiota with prebiotics, probiotics, symbiotics, and postbiotics, and also with other epigenetic factor in adolescents and children, exercise, and what is more important to me, nutrition, individualized nutrition. I will not talk about the fecal transplant. If you want, we can discuss later. So there are potential application of probiotics, prebiotics for the prevention treatment of COVID-19. And it's not a surprise, because the gut and the respiratory tract share the same embryonic origin. And also probiotics and prebiotics could be applied to prevent or treat COVID-19 waiting for the vaccine. And there are papers in the literature like this. It's possible to restore the gut microbiota to have an improvement of the lung microbiota of the lung respiratory disease. So it's really possible in experimental animal to perform all these things and have an improved respiratory health. But it's very interesting, because the beneficial microbes are lactobacilli, and given intranasally and orally. So they are able to modify immunity, the immune system, and to improve our health. And a lot of papers, as you can see, I show only part of these papers. And what happens is that in humans, we can suggest lactobacilli, in particular lactobacillus bacteria and bifidobacteria, but also the two stars of the intestine later who colonize the infant and the child after 1 year and a half. So, is a healthy microbiome responsible for lower mortality? Please look what is suggested by papers of the literature, like Bacillus subtilis, Lactobacilli gasseri, Lactobacillus rhamnosus, and because some of these bacteria are able to increase secretory IgA in a very fast way. Please look after 2 days. So it is possible also to use this lactobacilli to prevent other respiratory infectious disease, like for RSV. And finally, I want to show that it's possible to perform fantastic study with the so-called chips, the stem cell-based lung on chips. So it is possible. This is the gut, and this is an example of personalized medicine application in research. And we can have also excellent information by the use of human bronchial organoids, also human cells. So I'm finishing. Our personal war against the virus is we are looking to all metabolomics of the urine of infant of mothers of with positive to the infection, and newborns and infant positive to infection. With all my fellows, we published a lot of papers, and within the end of the year will be about 17 papers published in PubMed. And these are my collaborator and all the names of the fellows. And Professor Fa, studying the microbiome, my fantastic group of metabolomics. So something to remember, the 3 M's, microbiomics, metabolomics, machine learning, artificial intelligence. The president of the Italian Society of Pediatrics, 11,000 pediatricians in Italy, wrote that before coronavirus and after the coronavirus, nothing will be like before. So I think we must approach, and I'm finishing with my last slide, all this topic and all the topic of science with the wisdom of humility. The only wisdom we can hope to acquire is the wisdom of humility. Humility is endless. And I thank you very much for your attention.
Thank you, Professor Fanos. We were more than fascinated by your nice, great lecture, and I was taking notes myself indeed. I encourage audiences to use the chat section to ask their questions, and we will ask the lecturers each questions at the end of their sessions. And now, next we will have Professor Ravelli to tell us about classification criteria for macrophage activating syndrome complicating systemic juvenile idiopathic arthritis. Professor Ravelli, hi, thanks for joining us today. Yes, I have made it.
Thank you very much. I thought there was another lecture before my my lecture, so but anyway.
Yes, Professor, the program has changed just a little, but if you are agree, we will have your
yes, no
lecture.
problem. Yeah, no problem. I was not yet
much.
ready, but we'll be ready shortly.
Okay. Can I have a question while Dr. Ravelli is getting ready? Is it okay if I have
sure.
That gives
Yes.
a bit of time to Professor Ravelli as well. Is that okay, Professor Ravelli?
Could be? Can you?
Can I have a few minutes before you start?
Yeah, no problem. Of course, no problem.
I ask a question from Professor Fanos.
Of course, no problem.
Is Professor Fanos available?
Here I am.
Easy.
You.
Okay. Thank you. Wonderful. What a wonderful.
Ciao, Vassilios.
Thank you so much.
Carissimo, ciao. We were talking Italian, speaking Italian.
We can speak Italian, so I guess few of you
so we learn also Italian.
Understand.
Professor Fanos, what a wonderful lecture. It was amazing. It was amazing. So as you just mentioned, it's the 3 M's. So I have been fascinated. It was amazing. Thank you for this beautiful lecture. I'm sorry that I missed the yesterday lecture, but I will, thank God I can go back and look at the recorded one. Forgive my ignorance, but just as a person that doesn't really know much about the microbiota yet, and I'm not an expert in that field, out of curiosity, do you think that the relationship that we are finding on the fecal injection back to the fecal feeding back to the animals that we have experienced so far, having the obstructive sleep apnea not being an infection but being an inflammatory process, it of course is the same concept in a way. If you were to use a benign probiotic, what would be your just throw in the hat maybe choice of probiotic to maybe reverse? Yes,
thank you. I also appreciated your talk very much, and you paid the way to me, and I completely agree that this is a completely a new topic. Yesterday I told that I'm studying metabolomics for 14 years, and I moved to microbiomics necessarily after 1-2 years to study also microbiome because metabolomics is considered the Rosetta Stone of microbiomics. So what you are talking about is very interesting. If you look to germ-free animals, they don't have inflammatory and autoimmune disease. So this is a key message. They don't have asthma, they don't have eczema, they don't have a lot of disease, arthritis, rheumatoids, and so on. The last question, which is my preference, I told you that the old friends of the humans, lactobacilli, that are donated, is a gift that the mother gives with the vaginal secretions during vaginal delivery, and the bifidobacteria that are given mainly by the microbiome of the milk. So these two, which lactobacilli, those who are more studied in humans and in children, Reuteri, Lactobacillus gauteri, and Lactobacillus GG rhamnosus. This could be my, but in coronavirus, all the literature is Gasseri, Lactobacillus gasseri.
Gasseri.
But it's more difficult to find in the market. So
But,
the other two that I suggested to you have more than 500 papers published.
Wow.
So it's important because there is a specificity of the type of the microbe. So it is not that one fits all. There is specificity of the bacteria.
Another ignorant question, so Dr. Ravelli can have more time. Again, I'm showing my ignorance. How much time it would take? Maybe let's say we just designed this simple experiment. Somebody has some disease, we want to treat it, give it let's say one of these bifidobacteria or whatever, lactobacilli. Okay, how long should I give it?
Yes,
how much time to change
yes, it's a very generic question. So I say it depends on the disease. What I can say is that a very important thing today is the socio-microbiology of bacteria, or it was published in Italian, a book, Anthropology of the Bacteria. If we look at life on the earth, all the period of life in the earth, one day, we are living only in the last 5 seconds compared to bacteria. So I don't know if we are imitating bacteria or it's the opposite thing. And normally, it is important to modify the whole microbiome. We are used to the Koch postulate, one bacterium, one disease. No, in this case is the socio-microbiology, the importance of the different species in the consortium. So I think that normally you can have to change a microbiome, I think 1 year.
1 year.
To have, yes, but to have positive and beneficial effects, I think that 1 to 3 months you can observe
actual change,
yes,
significant
yes,
change.
yes. And what happens is that if you give bacteria, the bacteria produce metabolites in relation with the food, and the metabolites are the words when the cells have a dialogue with the bacteria, they use the words of the metabolites. So they are the secret language of the bacteria and the cells, and the axis of our organism.
Maybe the exosomes. Maybe the exosomes. Maybe, but so you would think that maybe 4 weeks, 8 weeks, maybe 12 weeks maximum, we would be able to see something significant change.
You can find modifications that are, of course, detectable with sophisticated analysis like the omics. So you can see the modification of a well-being, and also on the opposite side, if you have a pathology, even important, but without clinical signs, you can capture very early diagnosis of what's happening in the organism. And if you are used to know this secret language, you can understand everything. Yesterday, I showed some slides on personalized medicine, on the modification of in single individuals with autistic spectrum disorders, Pandas disease, or other fibromyalgia, with very important clinical results. It's not experiments on mouse.
Yes.
Clinical result in humans.
Yeah.
This is my opinion.
Absolutely. Thank you very, very much. I appreciate your thorough answer. It was wonderful.
I did a good job for Professor Ravelli. I hope so.
Oh yeah, we did our best.
You definitely did.